want to thank the members for taking part in this afternoon's exchange with our officials from the Department of Human Services. We will start with the members who have requested recognition for a second round. For 10 minutes, starting with Chairman Haywood, and then on to members, starting with Senator Phillips Hill.
Thank you very much. Thank you for the presentations and response to questions from this morning. I have a few new questions and one follow-up question. One of my new questions related to TANF and the amount for families having been stuck at the same number for over a generation. We still have $403 for a family of 3. I think we've been at that number since about 1990. Obviously, costs have gone up, and I know an effort was to allocate block grants more toward child care, but it's obviously hard to defend $403 for a family of 3 having been established in 1990. What, if anything, can we do about that?
Thank you for the question. I will turn it over to Gloria and Inez to talk specifically about that, but you are right that a family of 3 with no income receiving ongoing TANF cash assistance receives $403 a month in cash benefits, which is not a substantial amount of money, but do you want to talk specifically?
Sure. And you are absolutely correct that the benefit amount for TANF families has not increased in the past 30 years. But over the last couple of years, we have done things to try to mitigate that. So individuals who receive income or start working while they're receiving TANF, we make a bridge from TANF to work, allowing those individuals to still collect $100 for up to 3 months after their TANF case closes. In addition to that, individuals who gain employment and their TANF closes, they maintain SNAP benefits at the same amount for 5 months after their TANF closes. So the administration has made a significant investment in child care, which is one area that helps to alleviate and get people from receiving our benefits to working and working successfully.
Obviously, that's a serious concern. My next question is related to the transition for individuals who are incarcerated to home. So I've met with individuals from a very successful group called Why Not Prosper in Philadelphia, and they assist women who have been incarcerated, pick them up often at the location of the prison, but have had a number of challenges seeing that these individuals get the same prescriptions, that they don't lose their access to prescription medicine, especially is a major concern, obviously, for some of these, access to health care and the prescriptions are key. We understand there's some discrepancy by county as to where the transitions are easier and not as easy. But if you're aware of this challenge, well, you're now aware of it, but if you were aware of it prior to me raising it, I'd be interested in how you see responding so that there's not a gap of a month for people who really need prescriptions now.
Absolutely. Well, one of the things we've done as an administration is implement a process to suspend Medicaid benefits for individuals who are incarcerated rather than terminate them upon incarceration to help promote seamless transition out of an institutional setting back into the community without a lapse in that healthcare coverage for those who are MA eligible. The hard-to-place cases or individuals who are coming out of congregate care settings that have challenging or complex needs that make it difficult to find housing, for example. It might be behavioral health needs. It might be that they have a history of sex offenses in their background. Whatever the situation might be, it is still our responsibility to ensure that they have a safe place to go when they are discharged from an institutional setting and back into the community. We have proposed an initiative to create up to 18 beds in the Warren State Hospital facility to provide bed space or capacity specifically for those complex cases that are coming out of the state correctional institutions and back into the community. It's a pilot. We're hopeful that if we see some success there, that we're able to replicate that in other places around the state.
Thank you. So is that the Hard to Place initiative or something else?
That is the Hard to Place initiative, and I apologize, I conflated the issues this morning because we serve a variety of complex individuals across our systems. But this is one budget initiative where we have put, I think, $7 million aside to support up to 18 beds at Warren State Hospital for that complex population.
Thank you. I have very, very serious concerns about particularly women. I've got a video. I might show you this video. I've got a video of an individual who's sharing her concerns about having left an institution and then being without assistance. But thank you for this new program, and I think the suspension approach is definitely superior to termination. Also wanted to ask you about adult protective regulations and the services for those ages 18 to 59 under Act 70 of 2010. And it's been a while since this legislation has been passed. Wanted to hear from you any kind of updates on how the adult protective services regulations are going, any kind of updates you have on how we are serving individuals who may need such protective services.
Absolutely. So we do recognize that the legislation was passed some time ago, and we expect that the standing committees will have those regulations for review in the spring. So making pretty good progress there.
Thank you so much. Thank you, Mr. Chair.
Thank you, Senator Haywood. We'll turn to members, starting with Senator Argyle, followed by Senator Schwank for 5 minutes.
Thank you, Mr. Chairman. Many of us at previous hearings reviewing this budget have mentioned the concern that the governor's proposed budget could leave us with a $13 billion deficit in a few years after he has left the Capitol. And there's a lot of argument about whether that's possible or not. The state treasurer, during our discussion on that possible deficit, reminded us that a budget is about two things. It's about money coming in and money going out. Your department is the largest recipient of taxpayer funds, of course, and the governor has suggested that we give you a record increase. I've spoken with several of your predecessors about the fact that hundreds of thousands of non-disabled adults are receiving assistance through your department, and I'm struggling with this. Is that number improving, or is that number growing even larger? I understand during COVID everything changed, and I was wondering if you could give us some updated data on that.
Yeah, I will say that Pennsylvania is an aging state. We certainly see more seniors coming onto the Medicaid program, more individuals with disabilities.
But I'm not talking about those. I'm talking about non-disabled adults between 19 and 64.
In terms of specifically what their numbers are in terms of growth, Gloria,
Yes.
can you speak to that?
Yeah, I don't have those numbers with us, but we can certainly get them to you.
Okay, because, you know, I don't think any of us want to force someone's great-grandma to take a job at McDonald's or a coal mine. But if there is someone that's receiving assistance through your department who wants to go to work every day, who has the ability to go to work every day, I think we ought to be encouraging that. Is your department placing any more of an emphasis on getting those people back to work than in previous years?
Absolutely. So recognizing that there are a number of people that are adults without disabilities that are receiving Medicaid, I think it's important to point out that Medicaid is not a welfare program. It is a health insurance program. And there aren't many health insurance programs that have work requirements attached to them. But that said, we've certainly heard concerns from the General Assembly about getting more people back into the economy, particularly coming out of the pandemic. We have a MA work supports program in place that voluntarily asks individuals at the time of enrollment into the Medicaid program if they're interested in job supports, and then we refer out from there. Inez can talk a little bit more specifically about those programs, but we do have a heavy emphasis on employment and training and making sure that people are able to get back into the workforce if that's appropriate.
And so, as the acting secretary said, we do want to support individuals in gaining family-sustaining jobs. So as she mentioned, the MA Supports Program asks individuals if they want help in getting job services, and we provide those with us. It's a collaboration with our managed care organizations and also with CareerLink in providing them information about getting and obtaining a job. In addition to that, for our TANF clients, we did redesign our employment and training program in 2020 to focus on making sure people had the supports they needed to get jobs that they could be successful at and also leave our roles because they are successful at having a job that pays them a good wage and they no longer need our assistance.
I think it's win-win. The minority chairman correctly pointed out that, there are people in desperate need who we'd like to help more. If we are successful in returning more recipients to the workforce, then we can afford to help even more people who are in desperate need. In grad school, we spent a lot of time on benchmarking. Has your department set a goal on trying to get able-bodied recipients of some form of taxpayer assistance back into the workforce? A 5%, a 10%, a 90%? What's the goal?
So in our employment and training programs, we do a referral to enrollment rate that we look at, and that has increased since our redesign from 2020 to 2021 at 14%. In addition to that, we look at job placement, job retention. I don't have those rates right now in front of me, but we do look at making sure that we are increasing those rates year over year.
I will also say the average time that a non-disabled adult is on the Medicaid program right now is about 10 months. So there's pretty significant churn, which I think is a good indicator that people are able to get back into the workforce.
Thank you. My time has expired, but any additional information that you can provide to the members of this committee, I think would be, much appreciated by all of us. Thank you.
Thank you.
Thank you, Senator Orgel. Senator Schwank, followed by Senator Mensch.
Thank you, Mr. Chairman. I'm glad to be back to ask you some questions. Thank you for returning this afternoon. You didn't have a choice, though, I don't
sure
think.
didn't.
In 2019, Governor Wolf issued an executive order regarding vulnerable populations, vulnerable people. And within that, that order was the establishment of the Office of Child Advocate, which I was so happy to see because I spent a number of years talking about that along with other advocates and the importance of having an independent office to look at some of the issues regarding, services that children are provided, particularly within county offices, and the state budget as it relates to children as well. So we have a child advocate right now. I noticed in the budget we are supporting the court-appointed, the CASA program, which I thoroughly support as well. But I don't see anything about this Office of the Child Advocate. And I assume that it's incorporated into some part of the budget. My concern is, what are the plans going forward? Governor Wolf, this is his last term, his last year. And so what are your plans for that office? What do you think will happen? Because I think it's essential to have that independent voice like we do for seniors and for consumers. We have advocates, and children are certainly a vulnerable population. Can you discuss that at all?
Yeah, I mean, I think that absolutely having a child advocate is a win across the board, to provide that voice of independence for kids that are involved in the child welfare system or just in general, right? The CASA, the benefit to the CASA program and being able to expand that into other counties, so that's court-appointed special advocates to allow for more volunteers that can help support kids through their court proceedings and hopefully into placement in a positive way. I think Gloria may be able to touch more on the particulars around the child advocate in terms of funding.
Yep, so the department's budget doesn't include costs for the advocacy office, but we do see increases in the county child welfare appropriation, which is the dollars, most people think of it as the needs-based plan and budget in the county child welfare world. So there are significant increases in the needs-based line. It looks larger than last year, but a lot of that is coming out of the pandemic and reverting back to pre-pandemic levels. So I think we see the increase in the services that the counties are providing, and they are being responsive to the needs in their particular community, but the advocate is outside of the DHS budget.
So you're saying to me that the funding for the advocate is in, I think it's about 92 million that you allocated for children and youth services on the county level. Is that where you're saying the money is coming from? Or am I not hearing you correctly?
It's not in the DHS budget at all. The advocate.
Not at all?
No, it's not in the DHS budget.
So it has to be covered through that?
That is a staff position, I believe, through the governor's office.
The governor's office?
Yes.
Okay. Well, then, again, is there any thought to what will happen in the future in regards to that office? Because it is essential to your operation and your mission in terms of protecting children and families.
Yeah, the next couple months will be really important as part of the transition conversation to ensure that these positions continue to be upheld and carried forward into the next administration. John Rubin might be able to shed some additional light onto what we're doing to support the Office of the Child Advocate, but Gloria is correct that it's funded in the governor's executive budget, not the department.
And that makes sense, and that's good because that just enforces that independence that we need to have. Hi, John.
Hi, well, I think you just said what I was going to say. So I will share that we've worked collaboratively with the child advocate and certainly support assuring that we don't duplicate roles, but that they are an independent voice. And I think the thought would be that if they were under our funding and if we were overseeing the child advocate, it wouldn't be viewed as independent. So.
Would you support, it sounds to me like what we need to do is have some sort of legislative, we have to put this in statute, that this office exists and that it is funded. Would you support legislation like that?
Yes, and I've worked with the current child advocate to look at the legislative and what other states do as well. So we've provided our support to those discussions, yes.
I would be interested in having a follow-up conversation with you about that because I see time is passing and we need to make sure, I think the current advocate is doing an outstanding job and I want to make sure that we continue that kind of good work regardless of who the individual is within that office. It's critically important. And within the children and youth services budget itself, are there any special initiatives that you are asking county offices to take on, or are there particular things that budget includes that it didn't before?
Well, we're certainly fundamentally trying to change the whole child welfare system to be more upstream and prevention-oriented. And we are working with the counties to build in more evidence-based practices and to be more prevention-oriented. So as Gloria talked earlier about the increases in the budget, it really is meant to implement some of these evidence-based practices as part of our Family First initiative. And again, I'm happy to talk to you more about those pieces. It's meant to help support prevention, have fewer kids coming into out-of-home care, and keep kids at home safely and with evidence-based practices in communities. We are also doing a lot to try to strengthen community services and really build from the ground up in a sustainable way community prevention programs, and we're working with the counties around that.
That's kind of an emphasis that the federal legislation that has put in place, and so we're following through as a Commonwealth in terms of making sure that our county agencies do that as well.
Yes,
and that's
absolutely.
a goal we should all support, for sure. Prevention rather than after the fact, and with the needs of children and families first. So I appreciate that. Thank you very much. Thank you.
Thank you, Senator Schwank. Senator Mensch, followed by Senator Street.
Secretary and team, good afternoon.
Good afternoon.
You need to get up and spin around a little bit.
I had a Diet Coke at lunch. I should be good to go.
Good for you. I'm sure Dr. Atkins could talk to you about it.
Yeah.
I'm going to talk about MCOs and a remaining problem with MCO PH, which is the physical health. I will tell you that a couple of years ago I had in my district some MCO issues. I worked with Kristen Crawford from your office. She was able to marshal the appropriate people together. I think we resolved it. But from the report that I have in front of me now, there still remains an area with physical health. I'm not sure where all the differentiations are in MCOs. But it's the same issue that we had before, and that is a lagging reimbursement to the MCO itself. They have a responsibility, and you measure how effectively they pay their providers. I believe they have to meet 95% in 30 days. But their cash flow very often lags by 6 weeks to 2 months, 3 months. And that's caused because of when we went from prospective to a retrospective payment process for the MCOs, they began to lag in their reimbursement. It remains in MCO physical health. I'm not sure if you're aware of it, but is it something that your department is looking at, or is this something that we can easily resolve? It's got, ultimately, it's the end user is the patient. It's not, we have the MCO and the provider wrestling with one another because of payment process being slowed, but it's ultimately the constituent that's suffering.
There have in the past, before the beginning of the PHE, we had a process in place by which there was a delay in the issuance of a payment. That process was put on hold at the beginning of the PHE and is not currently in place. So if you're still hearing concerns, that's something that would be really helpful for us to know and to have more conversation about. But what you're referring to, I believe, is prudent pay, which was it's essentially a built-in delay to issue a payment. That has not been in place since the beginning of the PHE.
I would confidentially like to refer this individual to your office so you can have that conversation.
Absolutely.
Okay, thank you. The Secretary, I want to go to something else entirely different. 9 years ago, it's hard to believe, but 9 years ago I was the chairman of Aging and Youth. And we were working on a statewide project on Alzheimer's disease, and I believe we had 14 meetings around the state with stakeholders, organizations, families that were affected. And one of the critical things that came out of it was education, that we needed to educate the population more about the onset of Alzheimer's, what to look for, what are the problems, where can they find funding if they need to renovate the home, put in new bathroom facilities or a ramp to get into the front door and so forth. Every year I've asked the Department of Aging for, what are we doing? And the best I get is we farmed it out to another organization. But we compiled a great deal of information, and I told them at the time that we were doing this, that my greatest fear was that we were going to compile all this information, put it in the binders, and it would sit on a shelf and collect dust. I see now that your department is assuming some responsibilities for the additional education. I would like you to talk about what is that additional education, how are we going to be reaching out to people? And in closing, I'll say my experience in government has been that we generate an awful lot of information, but we're very lousy at getting it to the public. So what are we doing to provide more education on Alzheimer's?
Absolutely. So I will begin to answer the question, but I will ask Jamie Buchenauer to rejoin me at the table. She's our OLTL deputy, and I think can speak more specifically about what we're doing to recognize the oncoming crisis that is Alzheimer's care.
It is an oncoming crisis. Tsunami is how I
Yeah,
refer to it,
yeah.
yes.
We are certainly, in our 2022 CHC agreements, we included a complex care unit to ensure that all participants with complex circumstances such as traumatic brain injury, ventilator dependence, et cetera, are able to receive all of the necessary supports and services in a timely manner. We participate in the Department of Aging's Alzheimer's Task Force. And Jamie, I will let you speak more specifically to other activities that we undertake related to Alzheimer's.
Absolutely. And so I think you're talking about Act 9, which was recently passed, that required the Department of Health to come up with a toolkit.
That's correct, yes.
Yes. And so our role in that will be the dissemination of information from the toolkit onto our CHC MCOs and our providers. We have a lot of tools that we can use to disseminate information, especially on Alzheimer's. We also have the ability to hold trainings with providers about any information that the Department of Health and we collaboratively come up with. I will say that, we did a really good job of training and dissemination of information around COVID, because people with Alzheimer's and related dementias obviously had COVID-related issues. And so we did a lot of training for nursing facilities, personal care homes, assisted living, and our home and community-based providers, specifically about how to keep those populations safe during COVID. So we have a good foundation.
I think so. It's a shame that we took a second crisis to inform people about the first crisis. And I just think that my father had Alzheimer's, and I've seen the effect it has in a family, and I know so many friends, probably people right in this room, have had relatives, friends. It's a very difficult disease to cope with, and the more that we can educate the community front end before it actually occurs, the further we'll be ahead of that game. So thank you very much.
Thanks, Senator Mensch. Senator Street, followed by Senator Phillips Hill.
Okay. Can you discuss, one, good afternoon, welcome back. Can you discuss the department's efforts to help ensure that there's high-quality access to care at hospitals and facilities that are operating in disproportionately low-income communities that have high public pay, where there's high public pay? Given that, healthcare costs have gone up in some communities, people are largely dependent on public pay. What kinds of efforts are we doing to ensure that in those communities we still have high-level access to care?
So we are always, top of mind is ensuring that we have appropriate staff ratios in place and that we're able to provide a safe, institutional setting for people if that is where they choose to live. Certainly costs are increasing as more and more, as the state ages or grays, depending on how you refer to it. And we recognize that areas that have been disproportionately affected by things like redlining and just historic rates of poverty, that the COVID-19 pandemic has exacerbated a lot of those situations for people. We can talk more specifically about what we're doing in that space as it relates to the MCOs, and maybe we should focus a little bit on our efforts around value-based payments and better services for people in those communities.
Yeah, and not just nursing homes or institutional care, but also just hospitals and, because in some communities, almost all of the medical service providers are relying on public pay.
I think there are a number of activities that have happened over the pandemic to help infuse dollars into some of those hospitals. And the most recent, thank you for those who helped make this happen, is Act 2 of 22, which really put out $210 million to hospitals and behavioral health providers. I think it's not the only infusion of funds that have gone to help hospitals through this time. But when it comes to the MCOs, I think Meg talked a little bit about this value-based incentives. We have pay for performance. There are activities that we put in place to help make sure that the services that are being provided are necessary. So there are incentives in that way built into the contract, but it's certainly something that we're aware of and supportive of additional help to those hospitals.
Okay. Yeah, thank you. And then I guess my second question, if you could discuss a little bit about what the impact would be for the communities that you serve, the low-income communities you serve, if there was an increase in the minimum wage. What would that do to the need for services? Because we know there was a cascading set of effects. And
Let me find my minimum wage tab. The minimum wage, I mean, we have a embarrassingly low minimum wage in Pennsylvania at $7.25 an hour. The governor's proposal to raise that to $12 an hour with a path to 15. We're well past the time where we need to move on raising the minimum wage to help lift people out of poverty. We can talk more specifically about the impacts that it would have on our population, unless Gloria has found the information before me.
So I think we see the impact of minimum wage in a couple areas across the budget. We do anticipate that people will actually come off of the MA rolls when we move to a $12 an hour. We expect to see both adults and children transition from the Medicaid capitated program. We expect to see increased costs in the areas of county child welfare, child care services, child care assistance. We don't plan for an impact immediately in the Community Health Choices program. That's a little further down the road. But I think we anticipate really seeing the ability for people to come off of the healthcare program, the medical program, and that means that they might transition to Penny, the children may transition to CHIP. I'd say that's the biggest impact. In addition to SNAP, I think at $12 an hour, we estimate 15,000 people will come off of the SNAP program.
okay. Look, I think that's important. I think it's also important to recognize, look, there are whole sets of circumstances that drive the cost structure that you all are dealing with, some of which have to do with what's going on with the overall economy, what happened with COVID, people being laid off, obviously, in Brexit. But also there can be positive things. So if we were to increase the minimum wage, that would certainly have an impact on people that are served. And I want to thank you for making sure we continue to have a focus on those most vulnerable communities and making sure they're able to receive services. I see my time is up. Well, I enjoyed talking with you.
Thank you, Senator. Senator Phillips Hill, followed by Senator Carney.
Thank you, and good afternoon, Acting Secretary Sneed. I understand that OCDEL issued a guidance to child care providers on December 20th of 2021 regarding protocols for children returning to child care facilities and child care centers. Could you please tell us what that guidance tells families to do?
Yes, and actually, Trace Campanini, if you could rejoin me at the table.
We were issuing guidance on that date to inform people that we recognized that COVID-19 had been added to the communicable diseases list. As such, we have child care regulations that require children and staff who are suspected of having a communicable disease to return to care with a doctor's note or a certified registered practitioner's note in our child care regulations. So we communicated to the field that we recognized the distinction, or previously we had been understanding that COVID-19 was a reportable disease, but that now we recognize that it should be falling under, that there should be no distinction between reportable and communicable, and in order to return, we should be following our regulations.
So is a note from the pediatrician part of the CDC's guidance for returning to these facilities?
It is not. The CDC's guidance really is a combination of time and symptoms tracking.
Okay, so if not, why is it included in OCDEL's guidance?
The guidance is based, it was a tool that was used to highlight the chapter 55 PA Code 3270, 3280, and 3290 child care regulations. And so we were calling out to providers' attention that we understood that we needed to enforce those regulations and that to return to care, staff and children should have a note.
Well, my understanding is that this has caused a significant issue for families needing to return to work and therefore their children returning to childcare. And this is not a new issue. serving on the truancy task force in York County, having been involved with the update to truancy laws, we saw a very similar thing happen because there was confusion over what needed to be done. And what we were hearing was that pediatricians' offices were packed with people whose children were not sick simply because they thought they needed a note to go back to school. So there is a backlog at pediatricians' offices right now, and not to mention that this is unnecessary. So given that much of the COVID-19 testing is occurring at home, using at-home rapid tests, not being administered in doctors' offices, what can you do? What is your plan? How are you going to remediate this issue? Because we're seeing a tremendous amount of confusions. Pediatricians' offices need to be a place where people who are sick can get care. You have testified to it here today, that there's a lot of pressure on our healthcare providers. There's shortages in terms of staffing, and yet we're pushing people into doctors' offices to get notes that, according to the CDC, they don't need once their child is well in order to go back to childcare. So how are you going to fix it?
So as soon as we issued the communication, we recognized the burden that this was going to place on providers, and we also heard from the medical community. We've elevated this to work with the legislature around, because we no longer have regulatory waiver authority on this specific issue.
But I guess my question is, you weren't doing this. It's not on the CDC list. So why are we in this predicament, and why do you need legislative action?
Because now that we recognize that it is a violation of our regulations, we do not want to act inappropriately around not enforcing the regulations that are in our PA code.
I will add to this that I, as a mom to a 4-year-old that has just had her second week of full in-person instruction since the beginning of the year because of COVID closures, this is something that was an oversight for the first year and a half of the pandemic, where we were not enforcing it because we didn't recognize that it was included in our regulations. A legislative fix is the quickest way to get around having to provide a doctor's note.
Well, I will say this. I have legislation that would create an office of the repealer that this administration has said over and over again is not necessary. The fact that you don't actually know what's in your code, I think, points to the fact that it probably is necessary. Again, I have concerns that for a year and a half we don't enforce regulations that are on the book. We suddenly find them, and now we have created a problem for not only our healthcare providers, but our child care providers as well. So I would encourage you to rethink this and look to remedy the situation. The last thing we need is our pediatricians' offices overflowing with children who don't actually need to be there. So thank you. Thank you very much, Mr. Chairman.
Thank you, Senator Carney, followed by Senator Pittman.
Thank you, Mr. Chairman. Good afternoon.
Good afternoon.
I want to revisit some of my questions earlier around the child abuse medical evaluation and consultations. So my staff and I have reviewed research that was authored in part by 2 members of Pennsylvania's Task Force on Child Protection, Drs. Rachel Berger and Cindy Christian. Their brief suggests that other states have 2 key elements in their child protection strategies. Number 1 being a strong expectation, either in statute or administrative guidance, about children being connected to such expertise, especially for certain types of abuse, for example, sexual abuse, or the age of a child, for example, less than 3 years old. And then number 2, that some state level or regional infrastructure and standards so that accurate diagnosis of child abuse is not dependent on the child's zip code, or in our case, if the county child welfare agency sought funding for such services. So can you provide a little more context about any Pennsylvania-specific statutes or guidance that set forth the expectation that such medical evaluation or consultation, and whether you support moving towards tangible statewide infrastructure for example, like working with our CACs as a leverage point.
Thank you for the follow-up, and I will say I'm very familiar with that document that you referred to, and Dr. Berger and Dr. Christian and the others who have contributed to that, and I've had discussions with them. And I'm happy to continue that and pursue that in discussions with the legislature and the acting secretary. I will say that we do have an infrastructure through the child advocacy centers. Again, any county, as I said earlier, that requested in their needs-based budget to us, a collaboration with a doctor in their county. We're happy to support that. And we're happy to consider the use of other state funding and explore this issue further.
Okay, well, thank you for that. We look forward to continuing that conversation and working on those things with you. I wanted to shift real quick and talk about child detention centers. It's clear that youth detention centers are really no place for minors to rehabilitate. We certainly had issues in Delaware County with ours. We've had our share of facilities that have become sites for horrific child abuse, where minors are re-traumatized before they come out, even worse than they went in. So can you talk about what the best practices are for helping these at-risk kids recover from trauma and to eventually thrive? And does this budget accelerate the adoption of best practices for juvenile justice?
You want to just? No, well, I will say thank you again for the question, and I know the state has dedicated quite a bit of resources to the Juvenile Justice Task Force this past year and certain recommendations around that, and I want to acknowledge that and our participation with that and with the legislature moving forward, hoping to come to have some of those recommendations be implemented. That said, I mentioned earlier to an earlier question, I don't know if you're here, where I talked about prevention in regards to child welfare, and I would put that in the context of juvenile justice as well. That we know, and I've been to our juvenile justice facilities, and I've asked youth, how many of you had been involved in the child welfare system previously, had been in foster care, and had your family, and many of them had. So as I talk about strong community-based prevention programs, I am also talking about for the juvenile justice system. The idea of how do we best support youth who've been traumatized is to try to prevent the trauma before it happens. And that's really our statewide strategy, is to move a lot of our prevention efforts upstream and build stronger community supports. And I would agree with you in terms of youth in our facilities. We have been able to decrease the amount of youth in our juvenile justice facilities, and we continue to work on those strategies.
Well, thank you, and I wish you all the best in that continued work. I think I have time for one more. I just wanted to touch on direct care worker wages, if I could. It appears that poor wages and difficult working conditions account for a lot of the staffing shortages that we're seeing across many industries. When it comes to many of the essential services that this legislature tasks DHS with, we're seeing severe staff shortages in many regards. Can you tell us more about the direct care worker wages currently when it comes to long-term living systems such as nursing facilities? What are wages like today, and how would the governor's minimum wage proposal affect those wages?
Absolutely. So I think, and I will let others speak more specifically to their program offices, but we're seeing a real reckoning with the caring infrastructure in this country coming, hopefully, out of a pandemic, in that we are putting enormous responsibility on people to do jobs that they are often paid $9 or $10 an hour to do. And we're talking about helping somebody go to the bathroom or helping them change their clothes. These are challenging tasks to take on, even if it's a loved one that you're providing those services to. So these are folks that are doing work that is incredibly challenging, and it is certainly our responsibility to ensure that we shore them up and pay them appropriately for the services that they're providing. We have included a variety of wage increases in DHS's budget that Gloria can speak more specifically to.
Okay, thank you.
So specifically for minimum wage, when we looked at the data source that we used, which was from 2020, you won't find direct care workers necessarily as a category of individuals. So the closest we have is personal care aides. So the average that we used for the minimum wage calculation for those individuals was slightly over $12. So you don't actually see in the minimum wage forecast an impact to that particular, to the CHC appropriation, which is where the direct care workers are, until I think like year 4. I will say, though, that when we were looking at ways to invest our ARPA home and community-based services dollars, we certainly tried to look at how to implement a floor for a wage in that space, which is challenging. Largely, you've got a lot of fluctuations and variances across the state when it comes to direct care workers. Some are absolutely above 12, others are, to Meg's point earlier, at $9 or $10. It depends on where you are. So I think we recognize the need to invest some dollars there, which is the increase that you'll see paid for with ARPA dollars for the first year of $418 million. And that really is intended, if that's the 8% increase in CHC OBRA, to lift the personal assistance services up. That increase should, and our intention is that those dollars are passed down and do influence wages, but it's not something that we can absolutely control.
Well, I think we can all agree that those workers are incredibly critical to really to society in general, but certainly to that particular the people that they serve. And I know from personal experience with my mother-in-law had caregivers, that the fact that some of them were working 2 or 3 jobs, and that was during the pandemic, which is even worse because they were going from place to place and everything else. But I don't think comes as a surprise to anybody that this is one of the results of the pandemic, that we're seeing these kinds of shortages and this kind of willingness to find other work, I think is maybe the best way to put it. So thank you very much, and I'll keep my fingers crossed and hope we can actually make this work. Thank you, Mr. Chair.
Thank you. Senator Pittman, followed by Senator Zaval.
Thank you, Mr. Chairman. Good afternoon, Madam Secretary. I think we would agree that those receiving Medicaid insurance coverage are the most vulnerable among us. Is that fair to say?
Yes.
So disrupting their access to health care would be the last thing we would want to do.
Correct.
Okay. Well, my concern is that the language in your current Health Choices contract would do just that, as it relates to the labor agreements that has been discussed earlier. So what can we do to avoid that disruption?
Well, the department's core responsibility is ensuring network adequacy in the Health Choices program. So we will never jeopardize the network adequacy of our Medicaid program. But as I mentioned before, those contracts are out for signature right now. We're hopeful that through negotiations by the end of the month, we get to a place where we have signed contracts and we move forward with a July 1 implementation date for the Health Choices program.
So if you're not going to jeopardize network adequacy, even though you've identified my sole community hospital as being on the list that would be prohibited, that won't be the case?
Those contracts are not finalized yet, so it's difficult to know which providers would or would not be in the network based on that provision.
Well, you've identified providers that you believe to have had these interruptions in the past. One of those providers is my sole community hospital. If they are not in the Health Choices MCO, my community is severely disrupted in terms of access to care. So will they not be part of this?
If the health plan is able to determine that the network is adequate with that provision in there and that provider is excluded, then, I mean, you would find yourself in a situation where, yes, they might not be providing services in the Medicaid program if they have had a work stoppage in the last 5 years.
Okay, well, so I read this correctly. It says that a PHMCO may not include in its network any provider with a history of 1 or more work stoppages during the last 5 years. I don't see any exception for sole community hospitals or essential providers.
There are no exceptions included in that language. You are correct.
Okay, but your earlier statement to me was you would not disrupt the network, and I have a sole community provider hospital in my community. Obviously, if they're not in the Medicaid MCO, the network would be severely disrupted.
We are hopeful through the contracting process that the health plans come to the table and that we have finalized agreements by the end of the month.
Okay, you're 28 days away from wanting to have agreements in place. This seems to be a very large open question as to the language of this contract. I think it would be very important to have that clarified before those contracts are in agreement. Will
I
that happen?
certainly noted your concerns along with your colleagues that the language is problematic. It continues to be negotiated through the contractual process.
As you pointed out, you've been 6 years in legal battles to get to this point. And it seems that incendiary language like this in a contract will probably only cause those legal battles to continue. And if we're worried about ensuring network access to the most vulnerable in our Commonwealth, I think this kind of language doesn't help in that regard.
The department has the ability to waive that provision if a particular provider were to come forward with being unable to meet network adequacy. So we're hopeful that we shake out all of these issues in the coming weeks.
Yeah, having that shooken out before the contracts are in place would be important. And I want to understand more on what you mean by provider. Does that mean long-term care facilities?
It's any provider.
So long-term care facilities, hospitals, what about independent providers, a dental office? If 3 employees in a dentist office walk out one day because they're upset, is that a work stoppage?
Yes, as the language is written, that would justify a work stoppage.
So this could threaten every single provider in the Commonwealth who delivers Medicaid services?
For those who have had work stoppages, it would affect them, yes.
Okay. This seems to be awfully broad language. It surprises me that we have taken our most basic healthcare services and have started to inject labor relations into those contracts. I'd certainly hope that we see that removed at the risk of jeopardizing healthcare, because as I read this, if a young woman who is pregnant and is expected to deliver and lives 2 blocks from my Soul Community Hospital, they would not be able to deliver at that facility. They'd have to go elsewhere.
If that hospital was no longer in the network, yes.
Okay, that seems to be an essential part of the network, and so I would hope that that would be clarified. Thank you. Thank you, Mr. Chairman.
Thank you, Senator Saval, followed by Senator Vogel.
Thank you, Mr. Chairman. Good afternoon, Secretary. Good afternoon again. Good afternoon to everyone, your team. I wanted to follow up briefly on TANF dollars before moving on to a couple other topics, if that's okay. I believe it was Senator Haywood who was discussing the kind of payment. I'm also thinking about where TANF dollars, of course, it's block granted. They can be used. The guidelines can, I think, be quite broad about their uses. So, there's sort of 4 TANF purposes that are criteria. One of those is preventing and reducing the incidence of out-of-wedlock pregnancies, and that is apparently one of the purposes that apparently, I guess there are all 4 purposes that that crisis pregnancy centers apparently meet. And so I'm just wondering how DHS tracks whether these programs are meeting those TANF purposes and what sort of metrics the department uses.
Sure, so I think you're referring to, well, real alternatives, am I right? So do you want to dive in, and I will, in terms of how we monitor them and ensuring that they're providing services to.
I think what I'm hearing is a larger question just around how we ensure that we use federal dollars appropriately, specifically these TANF block grant dollars. And when we make decisions about how to utilize dollars, we absolutely look at what's the intent of the federal funding stream. And then we line up the choices that we make about the usages of the dollars with the federal funding allowability, and then we allocate that across programs. So you actually see TANF in a couple of places in the DHS budget. It's largely in the child care space. You see it in cash grants, you've got it in child welfare, and yes, you have it in breast cancer screening, I believe is where Real Alternatives is, in a small amount. So I'm not sure exactly if you had a more detailed question, but the large answer is we look at those funding streams and make sure that they're appropriate.
Well, I guess a detailed question on specifically on Real Alternatives might be that, for example, if the TANF purpose, if one of those TANF purposes is preventing and reducing the incidence of out-of-wedlock pregnancies, CPCs don't strike me as meeting that criterion by because they actively discourage the use of contraception and they don't provide or refer to contraception.
I don't know the details of the Real Alternatives Agreement, but I can say that when we make determinations about the use of funding, we do have to submit federal reports to the government to let them know how we're utilizing those dollars. They've determined this is an appropriate way for us to use the money.
Thank you. Thank you. That's helpful. Another topic, going back to something that you raised earlier, Secretary, which was just that we are an aging state. We have talked a little bit about direct care work in for our elderly population, and just in home care and the like. I want to talk a little bit about the kind of conditions under this work is done, and maybe just the fact that as I think we've started to experience in our state, a lot of people are seeking the ability to age in place. And so your Office of Long-Term Living, through Community Health Choices, works with MCOs that help homeowners fund adaptive modifications with Medicaid and Medicare dollars. And these funds, as I understand them, can be used to add ramps and stair lifts, to make bathrooms and kitchen modifications. They can't be used, however, for basic systems repairs like plumbing and electric. And so we've heard, and this seems to be a fairly common issue, is that someone who is eligible to raise up their toilet, for example, but who has plumbing issues as well, winds up unable to modify their bathroom because they have to fix the code violations first. So you have a kind of sequencing issue. And so I guess I'm asking whether you might support policies and programs that would help homeowners carry out those kind of required plumbing, electric, or other improvements necessary to achieve code compliance. And maybe if we could just talk about how, if you would, how those investments might increase the number of participants who are able to access these Medicaid and Medicare-funded adaptive modifications.
Sure. So, and Jamie, you might want to come back up to provide any additional support to my answer. We would absolutely be supportive of additional conversations around how to increase funding for home modifications. At the end of the day, this is funding that, by allowing people to address systemic issues within the setting in which they live, it keeps them in their communities longer, right? And that results in better infrastructure for folks who are going to age into the need for these services going forward. Do you want to talk more specifically about any other work we're doing around home modifications, or in particular?
Sure, absolutely. So we do, obviously, in the Community Health Choices program for our home and community-based population, have a program that provides home modifications. You are exactly right that sometimes if somebody has a code violation and it needs to be brought up to code, that is not covered under our CHC program. But we instruct our CHC MCOs to have their service coordinators reach out to community resources that may be available in that specific area to help that participant with that unexpected cost and to look at other options. Because obviously we do want to keep people in their homes and in their communities. That's where they want to be. And so we're looking at all options.
Got it. Thank you so much. I see I'm out of time. I don't know if there's yet time for a unprecedented third round, but I would take it if there is. So thank you so much, Mr. Chairman.
I think the Secretary's prepared for a 15-rounder, isn't she?
As many rounds as you'd like.
You, Senator Vogel, followed by Senator Stefano.
Thank you, Chairman. Good afternoon again. There's been a lot of talk so far this morning and this afternoon about child care and the lack thereof and everything, but I think just talk briefly about the Keystone Stars program. I think that's a great program. And how has the pandemic affected it? Is it more or less a step above some of the other ones that they're still able to function and be going, especially level 3 and 4 Stars programs? Are they still doing better, I guess, maybe than some of the average just child care providers in the communities?
Yeah, Keystone Stars is a really unique program that allows us to attach quality to child care providers on a scale of 1 to 4. I will tell you, when I was looking for child care options for my girls, we sought out a Star 4 provider. They are few and far between, which I think speaks to how challenging it is to meet those quality criteria that we set out for Star 3 and 4 providers. But we have made significant investments to improve that quality, to expand not just the number of Star 3 and 4 providers we have as they exist and providing support to them now, but incentivizing more providers to move from Star 1 and 2 to Star 3 and 4 to offer higher quality child care services in their communities.
Yeah, I've had several of the 3 and 4s in my district, and they're very, I've toured a few of them, they're very, very good facilities. Like you said, people search them out to
Yeah.
take their children there, yes. My next question, the state facilities, are we closing, Whitehaven and Polk? What is the status on the closure of those 2 facilities? Can you give us an update?
So I'll let Kristen Aaron speak more specifically to this, but right now we are looking at a closure date of November 30th of 2022.
Okay.
So in terms of the transition, we have been transitioning individuals out. The pandemic obviously created some delays in that. So we are definitely behind schedule. So extending the closure date to 11/30 will be very helpful. Our commitment, as we said when we announced the closures, that we will safely plan and do careful individualized planning with every resident to make sure that they're able to go to a setting of their choice upon closure.
So they're closing the end of November this year then?
I'm-
The end of
I couldn't-
November this year?
End of November this year, yes,
Okay.
2022.
Okay, thank you. Your budget includes an increase to the adult community autism program. This program is only available in 4 counties, from what I understand. Is there any thinking of moving it to more communities or statewide or something along those lines? Has it been a success or not, or?
Thanks for the question. The ACAP program, as we call it, is a great program. It is limited to 4 counties. It is a small program. It serves less than 200 people. At this time, we do not have any plans to expand that beyond those 4 counties. But what I will tell you is in 2017, our program expanded eligibility, our larger waivers that we have more capacity to serve people in, expanded eligibility to people of all ages with autism who meet the eligibility criteria. So we have been able, through those programs, to provide home and community-based services to a number of individuals, again, of all ages with autism through those means.
Okay, thank you. My last question, I guess, revolves around the lottery winnings and welfare benefits. I guess you obviously must have a system in place to, if somebody wins a big jackpot, that you have to be notified, and how you're notified, and what that, if a lump sum winning is considered income, or how does that work as far as them being notified, or them having to notify you, or how do you find out about it, I guess, is my question, I guess.
I believe it is an automated process that is conducted monthly. I'll let Inez speak to it.
Yes, so we do have an exchange with the Pennsylvania Lottery where we get information every month in regards to individuals who are receiving assistance and lottery winnings. The exact way that we count those lottery winnings varies based on the benefit program that folks are eligible for. So in some cases, it may be that it's counted as income in the month received and then resources in the month after. It may be, if it's a certain amount, that it makes the person ineligible for benefits for that month. So it does vary based on the program and also amounts. Some are as low as $500, then these provisions kick in, or it could be $3,500 where the provision kicks in. But we can give you specifics per program, but we do take into consideration lottery winnings, and they do affect benefits.
So how long would this affect them then? I mean, if you win a $50,000 jackpot, would that kick you off for a year or 2 years, or how does that work?
Yep. So again, it depends on the program, but in many cases, it counts as income and then resources, and $50,000 would be over the resource limit for our program. So it would be, you would not receive assistance for those months that you were over the resource limit.
Okay, thank you. Thank you, Chairman. Thank you. Appreciate it.
Senator Stefano, followed by Senator Gebhardt.
Thank you, Mr. Chairman. I'm going to follow up on Senator Vogel's previous question about the autism centers, and only in 4 counties. And which 4 counties are they, and why those counties were selected?
The decision for those 4 counties certainly precedes my deputate, so I can't tell you. That program started back in 2008, so I don't know why they were identified as the counties. But that is Dauphin, Chester, Lancaster, and I'm forgetting the 4th county right now.
I was curious as to the population density of those areas. That was my curiosity.
Yeah, they're more exurban and suburban counties. Yeah.
I have an autism school in my home city, and I have a special interest. That's why I had a question about it.
Well, and they're not schools. So that adult autism program is a home and community-based program. It's an integrated physical health, behavioral health, and home and community-based services. So individuals live in their own homes. In some cases, they do have residential habilitation, so they might live in a group home, but they're not center-based. It is all home and community-based.
This is my point of reference. That was all.
Okay, great.
All right. I do have a different question, though. Last year, your department had made an announcement about RISE PA and a new vendor that was going to implement that program in an easier way to connect constituents to its available programs. And I know then when you were appointed, that contract was canceled in order to set it on a sustainable path. I was curious if you could provide us why that was canceled and what path, is it on a sustainable path moving forward?
Sure. So that contract was part of an emergency procurement, and so it would have only been in place for 5 years, and we didn't feel like that was a very sustainable way to stand up the program. So wanted to reevaluate. RISE PA is a resource and referral tool for individuals who are interested in a variety of different services. It's a way to connect people outside of various program offices in one centralized spot. The way we are planning to move forward with that is by having the health information organizations, the HIOs, procure the RISE PA tool themselves. So that RFA should be out from the HIOs in the next month or so. Sally's nodding yes.
Okay. So it'll be shortly then we'll see that.
Yes, yes.
Okay. Thank you. And my last question will be homeless assistance, the program that you have. I see that it's being flat funded over the last several sessions. Can you give me some insight as to, I know in my community this is a growing need and throughout my district. How do you see that program, where it goes through every of the 67 counties? What program does that go through, and how is it addressing the growing need?
Sure. Inez, do you want to speak to HAP?
Yes. So the homeless assistance program is in every county. Actually, those are the same organizations that we are working with the emergency rental assistance program. Those were the same administrative entities that are responsible for that program. I would have to look into further specifics. Was there a particular question that you had about the HAP program?
I was just concerned about the growing need and how that was addressed with your current budget request being at level funded.
I will say, to the extent we're not proposing an increase in the HAP program, Inez is absolutely right that the ERAP program is being run through the HAP program. So we've added $1.4 billion in ERAP funding to move through that program, which will provide support certainly to individuals who are experiencing or are at risk of homelessness. So even though we're flat funding the homeless assistance provision or appropriation, there is significantly increased revenue to assist those populations from federal COVID funds.
I know those county programs that you're running through now are experiencing significant stress from the change in the federal programs, as I've gotten requests from them.
Oh, on ERAP, you mean?
On the homeless, the shelter programs.
See.
Yes. All right, thank you.
Thank you.
Mr. Chairman. That's the end of my questions today.
Thank you, Senator. Senator Gephardt, followed by Senator Loughlin.
Well, good afternoon. Thank you for coming back for round two. I don't know if I'll stick around for all 15 rounds, but I'm certainly happy to stick around for a few more. So I wanted to circle back to just a brief part of the conversation earlier where we had talked about the minimum wage rise, what effect raising it might have. And I thought one of the things that was interesting, I just wanted to learn a little bit more about it, is you had talked about as wages increase, you would see less demand on some of your programs, which hopefully would then drive some cost savings on that end. Can you maybe expand upon that a little bit?
Sure. So at $12 an hour, nearly 38,000 adults and 14,000 children would leave the Medicaid rolls, and over 15,000 people would leave the SNAP rolls. The net impact to the DHS budget in 22-23 is a savings of approximately $2.6 million. So we do, and Inez spoke a little bit earlier about some provisions we have in place to ensure that people don't automatically fall off a cliff once they hit a certain income, but that we can ease them into self-sufficiency.
I mean, that's all pretty exciting news. We certainly want to see as many people succeed that they possibly can. I think anybody that, I'm also a small business owner, so I think anybody that's in the business world also understands that in the last 18 months, certainly in the last 12 months, we have seen some historic increases in wages. In fact, I just saw a report the other day that had indicated that wages are rising at a historical pace right now compared to as far back as they had tracked statistics. So, I mean, even in my drive-in today, I saw 3 different signs where we had Rudders and Sheets offering $18 an hour for positions, and Lowe's was offering, $25.25. So I guess my question is, we've seen this historic rise, and the market is certainly driving that. There is a lack of employees available, and that is driving wages higher. So my question is, as we've seen that, have you seen a reduction in the demand on your services? And if you can you share some of those statistics that you've seen in the last 12 months?
Excuse me.
I think what you're asking is if we've seen less people come onto the TANF program, the SNAP program. I just want to make sure that's kind of the gist of
Yes,
what you're
I mean,
asking.
what my basic question is, we've seen wages rising significantly, and I'm wondering how much that has impacted a demand on your programs.
Yeah, I wouldn't say that we've necessarily seen a decrease in the reliance on our programs. In fact, we've actually seen increases in the TANF caseload, which is the first time in years that we're actually seeing that happen, just recently in the last couple months. So I wouldn't say that we've seen an impact, and that could be reflective of what we're experiencing in the childcare side, which is it's difficult to go back to work if you can't find reliable childcare. So I think there's lots of things that might be impacting that, but I would not say that we've seen a reduction in the usage of our programs.
Would you be okay with an agreement that you're going to continue to agree that you're going to continue to study that to let us know how that is working? As you know, I don't see wages decreasing in the near future. So I'm greatly interested in how that works.
Yeah, absolutely. I think we're committed to constantly taking a look at some of the initiatives we put forward. Minimum wage is something that obviously we use data from 2020. We expect new data to come out in 2022. We'll use that to do a relook at our estimates related to minimum wage. It's definitely, we're in, I think, uncharted territory with the increases that we're seeing in the market. So definitely a need to be responsive to those and to update our assumptions.
Thank you. That's all, Mr. Chairman.
Yes, thank you, Senator Loughlin, followed by Senator Robinson.
Thanks, Mr. Chairman, Acting Secretary. The questions that I have for my follow-up here are in relation to your enterprise licensing system. And before I even start on this, I'd like to know, is the vendor that you selected in any way at all tied to the same vendor that we're using for our unemployment system?
Not that I'm aware of.
Okay, thank you for that. Okay, sorry, that was a little off the wall. I realize that. But, so anyway, this is an appropriations hearing, and you're asking for $5.9 million for the enterprise licensing system. And the little bit of research that I did on this, you folks went out for an RFP in 2019. The vendor was selected in 2020. The testing was supposed to be done, virtually by now. And I guess the question I'm asking is, since this is brand-new software that we went out for an RFP and we're using it, why do we need almost $6 million more already when it's not even up and running 100%?
So the $5.9 million does support DHS's portion of the enterprise licensing system, which would impact, excuse me, there's something in my throat. The Department of Human Services, Health, Drug and Alcohol Programs, and Aging. It's intended to support all 4 agencies in more efficiently addressing licensing, so that we can look at things like non-compliance issues across departments rather than just in the vacuum of DHS's space. A lot of our facilities have co-located services inside them, so they might be providing drug and alcohol services and residential care. I'm kind of making those examples up. But using an enterprise case management or licensing system would allow us to deliver a lot more efficiencies and collaboration among departments as we look to streamline our licensing functions.
Yeah, I'm not disputing that, you know, the path that we're on there to be more efficient. I guess the question was, is the $6 million oversight in the RFP, or if it's like, you know, if they're trying to charge us an extra $6 million for something we already paid for, that's all. Yeah.
I see.
If you don't have the information at your fingertips, I understand that, but that's the question, and if you can get back to me on that, I would appreciate that.
Yeah, we'll certainly take that. I'm not familiar with what language was in the RFP initially, but it's not my understanding that this is $6 million that we didn't expect. So if that puts your mind at ease. It is, I think, not something that is just implemented overnight. There were different components. Essentially, it's a multi-year build. So it's certainly something we can follow up on.
Okay, I appreciate that. And then I just have one more question, if I still have time, right, Chairman? Okay. You know, part of your budget request, you have an initiative that you would like 15 additional staff for licensing, budgeting, and program support. And, you know, I just asked about the electronic licensing system, so why would it take more staff if this is going to be more efficient?
I can start. I'm sorry. So at any given time, 10% generally of our staff is in a constant state of flux. So we have about 16,000 employees in the Department of Human Services, and 10% of constant change is relatively normal, I would say, in that big of a workforce. At the end of the day, licensing is a human-to-human function, right? So when a licensing inspector goes into a facility, and if they're supported by technology, like the enterprise licensing system, thank you, you know, that is a bonus to streamline technologies that can support those workers. But at the end of the day, it is the staff that is doing that work and going into these facilities. And I think 15 staff in the grand scheme of 16,000 to support our licensing work is pretty low.
Yeah, and I think the only thing I'd add is that we talked earlier, I think, throughout our testimony about changes that we're making in the regulatory process for a number of our offices. So that certainly is added work when we talk about increasing or putting out revised or new regulations. Somebody has to follow up and make sure that there's compliance with those. So that's something else to take into consideration.
All right. Add anything else here? Mr. Chairman, I think that's good enough for now. Thank you for that, and I look forward to hearing back on a couple of those items. Thank you.
This is the follow-up, Madam Secretary. Just to reconcile the request for new positions against available vacancies. Can you just provide some context to that?
Sure. So actually, Gloria, do you want to dive in on that one?
So in the department's proposed budget, we do include a request for 19 positions in the GGO line and 15 positions in the county admin statewide line. In each of those appropriations, we do carry a number of vacancies, And I think there's often, I think it's looked at in a way that I wouldn't say is fair. So it's not that these positions are the same individuals who stay vacant. We have a lot of retirements and turnover, so that's the churn that Meg was talking about, the 10%. So I believe in the GGO line, right now we have roughly 55 to 60 vacancies, and I think we have somewhere between 85 and 95 vacancies in the county admin statewide line. But those are positions that we're in the process of filling. So these are not the licensing positions we're talking about. They're not the fiscal and program support. That's added positions on top of filling those vacancies. So we've taken a look at the licensing changes we're hoping to make, where we see gaps in the current process. We've taken a look at the fiscal gaps that we have. Certainly, we've seen an influx of federal dollars, and we know that there's additional reporting tied to those. So we're trying really to address some of those needs.
We're having significant challenges filling positions right now. Is that something that you're concerned about at all?
I'd say that that's fair. These are positions generally, we don't necessarily see the same challenges filling like you would in one of our state centers or our state hospitals. Certainly, these are professionals who generally are reporting into an office. We believe actually telework is a very marketable way to incentivize bringing individuals in. So that's something that we hope we'll see improvements in our ability to fill positions. I do think roughly 8 weeks is fair to say that it takes us to fill a vacancy.
Thank you for that answer.
You're welcome.
Appreciate it. Senator Robinson.
Thank you, Mr. Chairman, and thank you, Madam Secretary, for coming back for another round. Thank you to all your staff. A colleague of mine, Senator Vogel, had touched on the closures at Polk and Whitehaven, centers for individuals with intellectual disabilities. I was curious to see if you had talked to the families of the individuals in these centers and how they feel about the closures. Has there been ongoing communication with those families?
Yes, there has been ongoing communication over the last 36 months or since August of 2019 when we announced the closure. The transition planning that is conducted in those facilities is done with the individuals that are living there, their loved ones or family members, along with any providers that offer support to them. So those are ongoing conversations, and there is also active litigation out there to stop us from closing those facilities. But so some of those families we don't communicate with in the face of that litigation, but those are ongoing conversations.
Good, I'm glad to hear that, and I hope they continue, and we can bring them in to the conversation, bring all parties into the conversation. But, I know that there's a nationwide movement for persons with intellectual disabilities to live in community settings as opposed to an institution. Can you explain the level of care in both of those settings? And will these proposed closures raise the overall well-being and care for those persons with intellectual disabilities?
Absolutely. I will let Kirsten Ahrens.
So the level of care provided in our state-operated intermediate care facilities is the same level of care that is provided in our private intermediate care facilities, and the same eligibility criteria for our home and community-based services. So that level of care is the same across all of our programs. In terms of sort of acuity of the population, our state centers do serve, for large part, pretty acute population with pretty acute medical needs, behavioral needs. About 20% of the individuals that are served in our residential program, we've got 14,000 people in our home and community-based services that receive a residential service. About 20% of them have that same sort of highest acuity level. So just in terms of capacity to support people with some very challenging medical support needs, behavioral support needs, mental health support needs, our community system is well equipped to do that.
Good. From our prior committee meetings on this topic, I understand Selinsgrove and Ebensburg centers are available to accommodate those who will be placed within these closures. I'm concerned that these two facilities, however, are quite far away from families to visit. And these folks will be uprooted, which I imagine could lead to other issues with them transitioning. Can you explain the benefits of moving these residents to other facilities?
So, let me back up a little bit and just share this. Decisions like this are phenomenally difficult. The residents of Polk and Whitehaven, for many of them, that is the only home they have known. And so this is a decision that was made with great deliberation, as is each of those individual transitions. Taken great care to do each of those transitions. One of the principles that we have in that transition planning is ideally we are getting people closer to family. And we were successful with that with the Hamburg closure in 2018. With this closure so far, the majority of people have moved closer to family. So that will not be the case for everyone, but that is absolutely something that we strive to do. And individuals and families are involved in all of those decisions.
Good. I really appreciate your time. I can only imagine how difficult of a decision something like this could be. And I do appreciate the amount of time and effort that you've put into making this transition possible and seamless in any way that you can, if and when this would happen. So I look forward to further discussions with you and your department, and I yield the rest of my time. Thank you, Mr. Chairman.
Thank you, Senator. We do have limited time for a third round of questions. We will start with Senator Phillips Hill, followed by Senator Saval.
Thank you, Chairman. Madam Secretary, if I could, I'd like to follow up on our last line of questioning with regard to Ocdel. And you realized that you weren't following your regulations. Is that correct?
To clarify, and Trace, if you'll come back up, I believe that our regulations were not an issue until COVID was placed on the communicable and non-communicable disease list, which did not happen until.
So let me clarify. Our regulations point to the Department of Health's regulations, and we look specifically at Chapter 28, Code 2771, 76, and 154. So I'm going to acknowledge that we missed an opportunity here. We understood that COVID would have needed to be placed on those Department of Health code lists that explicitly call out specific diseases and communicable infections that our regulations point to. As we were moving into December of this year, in conversations with the Department of Health, it was clarified for us that they had the authority to announce COVID-19 as a communicable disease, not solely as a reportable disease, and that we should be adhering to our regulations around infections and communicable diseases that were listed in our regulations.
So who added COVID-19 to the communicable disease list?
So that's under the purview of the Department of Health.
Okay.
And so when we understood that, and that was clarified for us, we recognized that we needed to follow our regulatory practices, and that's when we developed the communication and issued the communication to the field.
And so how was it that you weren't aware that the Department of Health had added it to that list?
So we were looking at the list online. The Department of Health promulgates a list of reportable diseases, and so our staff and team were looking at the reporting requirement of when a child or staff person were identified as having COVID, that the child care facilities complied with the reporting requirements. We were continuing to look at the lists that were promulgated online with the specific diseases until those conversations began in the beginning of December.
So, do you know when when the Secretary of Health or whomever it was at the Department of Health, do you know when it was added to that list?
So when we've had follow-up discussions around this, the Department of Health, and when they began communicating around COVID at the beginning of the pandemic, they identified it as a communicable disease.
But it was never added to your regulations.
Our regulations point to the Department of Health regulations. And so when we go online and look at the Department of Health regulations for the chapters that I referenced, COVID-19 isn't currently listed there, and that was part of the confusion on our part.
I think that helps to provide some additional clarity. I walked away from our conversation still scratching my head.
No, and I realized, I thank you for the follow-up conversation.
Yes, and again, I would say, so we don't wind up overburdening particularly our pediatric healthcare providers, this should be addressed. And I thank you very much for that additional clarification. Thank you, Mr. Chairman.
Thank you, Senator Saval.
Thank you, Mr. Chairman. Thank you, Secretary Sneed. Thank you for your indulgence. Thank you so much. I mean, really, it's been a pleasure, and I just appreciate the thoroughness. It's quite a range of work that the department does, and quite a range of questions that you get asked to address. So I'm going to stick to that sense of wide-ranging questions. I just have a couple. One is about a specific piece of legislation which would involve your department, or actually maybe two specific pieces of legislation that have come through a committee that I serve on, which is the Aging and Youth Committee, which is Senate Bill 871 and House Bill 1737. Now these are not the same legislation, but they have a component that unifies them, which is that they would allow a county agency to seek a court order to compel drug tests in assessing a kind of parent's capacity to safely care for a child. I'll just say, up front, it's my position that these are poor public policy. Drug testing is often riddled with errors, and a single drug screen is of limited utility in this context. And critically, drug screening has been misused, in both our criminal justice and child welfare systems in harmful ways that target disproportionately poor and minority parents, leading to unnecessary family separation and other harms. And so I guess I'm asking whether your department supports these pieces of legislation.
So from a policy perspective, and just to clarify, those bills would allow county agencies to require drug testing, right? From a policy perspective, I agree with you. It does not make sense to mandate drug testing requirements specifically because people are poor.
Just to clarify, it would not, from a policy perspective, it would not be.
It's not prudent to pass legislation that would allow further targeting of individuals because of their income circumstances. Does that make sense?
Yes, so that.
Yes, please, John.
Thank you for the question. I'm John Rubin, Deputy Secretary for the Office of Children, Youth, and Families. And I will also echo, we always need to look at any policy or any recommendation that we have and not contribute further to the inequities of our child welfare or juvenile justice system, and recognizing the historical inequities in those systems. I want to be specific about what was being proposed. This is an amendment to the Child Protective Services Law and the language that is being proposed. So the way it's written is, it says, if there is evidence in the investigation that substance use may be a contributing factor causing the alleged abuse or neglect. So this is not a wide-ranging drug testing policy for caseworkers. It is only in the circumstances where there's evidence. It's not even if there's a mention of substance use in the family. It's if it's a contributing factor to alleged abuse or neglect. The county agency may seek a court order to compel appropriate drug and alcohol screening. So it's not giving the county caseworker the ability to require it, but to go to court, put the circumstances in front of the court, and explain that we believe drug testing is appropriate for the safety of the child. We have seen a lot of fatality and near fatality circumstances with young children where allegations of drug and alcohol use were a contributing factor. Really, I understand the nature of your question and appreciate it, but we are also trying to protect the lives of children in Pennsylvania. And that was the emphasis, the reason why we were proposing this amendment.
Absolutely, and of course, I think we share the need to ensure that protection. I think we do also understand the kind of nature of how drug tests and compelled drug tests have been used, and so it's unclear to me from the language what criteria would be used to determine when you would seek a compelled drug screen, how we ensure those criteria are followed. How we would keep statistics on how often we seek those screenings, the demographics of who would be screened. I mean, that's what seems to, does the nature of those questions make sense?
Well, I understand now that this happens already in our child welfare system, right? Allegations come in, and it's our job of our caseworkers to really engage with the family, work with the family, and try to assess the situation. Earlier comment was, we don't want to increase family separation. We don't want to increase children removed. And again, I want to emphasize, we share that value. And if you looked at our system over the number of recent years, you would see the decrease in number of kids coming in out of home care. If you heard me earlier, I'm very strong in trying to implement prevention practices in our communities to strengthen our communities. I agree with you philosophically. This is a very narrow opportunity for us that allows our caseworkers standing to be able to say, in the particular circumstance that we really feel a child's life is at risk, to be able to go to a court and ask a judge for the ability to have the parent tested.
I understand. We may disagree, I think, on the narrowness of this opportunity. I think it may actually be wider than, but I welcome further conversation on it, and I very much welcome this conversation that we had.
I'd be happy to have further conversation, also provide you some of the data on fatalities and near fatalities and the situations that arise, which led us to want to make this change.
Understood. Thank you so much. Thank you again, Mr. Chairman. Thank you, Secretary. Thank you for all your time today.
Thank you, Senator Sabal. Chairman Hughes.
Madam Secretary, how you doing? You all right?
I'm good.
Very good. Let's thank Chairman Brown for him being the gentleman that he is and bringing you the waters and all that kind of stuff. Everybody's good? It's been a long day, all right? You got the shuttle thing going on, easing out. That's good.
Shuttle would be a good idea, actually, now that you think of it. Yeah.
It's okay. It's all right. When it gets to me, it's getting close to the end. So let me just thank you for your stamina, for everyone, for your work. I wonder if you had lunch with my Lisa over here, because she's now coughing and stuff. Okay, hers is a sinus infection, so, you know. And so that's instructional. Mark was not well last week, and now, you know, you blame him. You know, question is, will I be still standing in a few minutes is the question. So look, let me just acknowledge this. We are approaching almost to the day when 2 years ago, everything shut down. Almost to the day. When I look it's March 8th, 2022, and it's almost 2 years to the day that we're approaching when everything shut down. Didn't have to, but it had to. And I won't editorialize on that statement. And I want to first just thank you and your predecessors and the entire operation for handling your work in a very difficult environment that we need to be real mindful of the hell that we've all gone through for the last 2 years and the hell that our respective constituents have gone through, and most of them being the most defenseless, the least resourced to manage a pandemic with a prevailing notion that science and smart public health measures don't matter. Okay? So I want to put this in a little context. Because we've been, and I think you've said it, and just about every secretary prior to your arrival today has said that they've been trying to manage this process in an unprecedented, never seen before environment. Whether it's trying to create jobs, DCED, trying to manage environmental issues, DEP, trying to deal with our natural resources, with DCNR, different work environments that we've all had to deal with. Every member of the Senate, every member of the House. Different work environments. Do you have a mask? Don't you have a mask? Do you have a vaccine? Did you want to get tested? Remember the early conversations you and I had about the simple idea about testing to make sure you're sick or not? So I want to thank all of you. And most importantly, I want to thank the nameless, faceless folks who work in this department for grinding it out in a very difficult environment, dealing with healthcare institutions, nursing homes, hospitals, child care facilities, all kinds of environments to help us navigate this very challenging environment where far too many family members and friends have gotten sick. They didn't need to. But I want to thank you. And I thank everyone in your operation. Because your team, 16,000, I think I heard it said, okay? As I said before, are dealing with least resourced individuals in our Commonwealth. Our brothers and sisters who we love and we care for, but come to the table with the fewest resources and the ability to defend themselves. And your challenge has been, and your team's challenge, all 16,000 of you, have been to deal with that. And I want to thank you. On behalf of me, my caucus, all right, and those folks who've gotten the help, not realized it, and maybe not said thank you on the front line. So I want to thank you. And please communicate that, okay? To whoever you need to communicate that to. We all need to be mindful of what we have been through in the last 2 years. 1, 2, 3, 4, 5 are all wearing masks. And I probably should have mine on too, okay? But I'm taking the liberty here, all right? Because I want to make sure it comes through loud and clear. So that being said, on the issue of minimum wage, I know you support the governor's position about raising the minimum wage. I know what it means for the folks that you serve. I know what it means for the folks who work in your environment. And I think there's not too many folks who work for you that are paid the minimum wage because they think there's been some administrative decisions along that line. So thank you very much. Thank you, Lisa. It's just as an editorial comment, it's great that in 2022 that the private sector has caught up with this issue about, raising folks' wages to attract talent and attract workers. It's 2022. I would remind folks the last minimum wage increase in Pennsylvania was federally mandated in 2009, and prior to that, it was when we, as the legislature, raised it in 2006, and the last one before that was 1997. So, 2009 to 2022, that's 13 years. And the private sector has finally caught up. And still, far too many people are not being paid the wage that they deserve to have, what we try to call a livable wage. Now, so just as we grapple with that, let's make sure we put, again, context is important, very important. Let me ask this question about workforce issues. I mean, just about every department that's come in front of us have talked about the internal workforce issues that they're confronting. The need to hire, the need to find people. It's been a challenge. The issue, I think, I think you said that the opportunity for being able to work from home has been, in some cases, an attraction to potentially fill in vacancies. Give us your thoughts about what kind of aggressive efforts that you need to do to respond to that. And I also want to get your feeling about the pressures on the external side of the equation, child care facilities, nursing facilities, things of that nature. The wage conversation was raised. And what can we do to help deal with it, both internal and external?
Well, thank you, Senator Hughes. I will try to unpack that question, and others should jump in as they see fit. I think we are certainly facing a workforce crisis everywhere we look. This is a real opportunity for us to look at how we define our caring infrastructure and promote it going forward so that history has a tendency to repeat itself, so that we all don't find ourselves when we need care at the end of the day desperately looking for solutions because we haven't learned lessons coming out of a pandemic. $12 an hour is a bare minimum that we can bring people up to in terms of a minimum wage. It is just that, a minimum wage. It is exactly what we need to do to help support more people being lifted out of poverty, more people coming off of public assistance roles and working towards self-sufficiency. I wish I could say I had all the solutions for how we address that workforce challenge, but just for a little bit of context, 41,000 direct support professionals are doing the work of 55,000 workers right now. DSP turnover is approaching 60%. Because these jobs are really, really challenging. There are a lot of things we can do to better utilize technology, innovation, modernization, better training and supports. Wages is a fundamental way to lift people out of poverty. Fundamental. Others should weigh in if there are other thoughts there, but I think there are little things we can do here and there in our program offices to really try and offset this crisis, but it is a crisis, and we need to take a holistic approach to how we address it, and that is where we see that it's raining cats and dogs, we apply the resources that we have to address those challenges so we don't find ourselves right back in the same place we were in March of 2020.
With respect to outreach to fill the vacancies that you have, do you have any new ways or new concepts that you're trying to deal with or trying to put in place to address that?
Yes, on technology initiatives in particular, Gloria, do you want to go into any specifics? And I will just say, to build on the point around enterprise licensing, technology is one component that allows us to sort of modernize our approach, but a lot of the work that DHS does is human-centered, and we can't take away that human-to-human touch point. But there are a lot of things that we can do to help improve efficiencies for our workers so that they can really focus on better delivery of services to people they're working with.
I think part of what we're working on is how to get people in the door, right, so that they can take advantage of all the efficiencies we're trying to put in place. And I think that's really what you're trying to get at, is what's our plan to try to bring more people in. We have been working with the Governor's Office of Administration on ways to essentially create a pipeline in multiple offices where people are coming out of college and potentially entering into the Commonwealth workforce. That's really where we'd like to see growth. When you look at the statistics around the numbers of people who work in the Commonwealth, their typical age group, we really don't have an influx of young individuals who come to the Commonwealth and potentially start their career, their long-term career here. So that really is, I think, the conversation that's been happening with the Governor's Office of Administration.
And so that's with the Office of Administration, correct? Yes. Okay, very good. We all need to pick that up. You are not the private sector. None of the secretaries are. None of the cabinet positions are. This is the service business, in the business to serve. And to the extent in the business to help people can be very fulfilling, right? That whole notion of helping someone get through an issue, get through a circumstance, can be a very fulfilling notion. Might be something that might be compelling to a young person coming out of college, or with some a couple years of some level of college under their belt, that they can find a position that has some history and that has some longevity and some career to it, helping somebody, improving somebody's circumstance. I'd like to explore that with you in the future, maybe folks with the Office of Administration. Last area, Secretary, I know this is something, it's housing, and I know it's something that is been part of your career for a long time, especially around homeless children, and the capacity that you have within your offices. We'll be having some conversation with some folks in that space in a couple of weeks. We'll want you to participate, or your appropriate designee participate in that. Any thoughts on what you think your office can do, your department, this massive, very important agency can do in that space?
Yeah, thank you. I started my career working with kids living in motels along Colfax Avenue in Denver, Colorado, which is Denver's main strip. And they've always been at the center of the work that I do. Those kids are experiencing homelessness. They're going to go on to face some of the most challenging circumstances you could possibly imagine. I have always been frustrated in my work that you have HUD as a federal agency over here, and you have CMS as a federal agency over here, and the two really don't speak the same language. There's not. Human Services hasn't traditionally been in the space of providing housing, but you can't possibly expect somebody to have good, positive health outcomes if they don't have a safe, stable place to live. That is fundamental for anybody's dignity and experience in life. I think there's a lot of room for us to grow in DHS in terms of how we address housing, and certainly working with our partners at the Department of Education who have homeless assistance services in place for kids, and DCD, which tends to have a lot of homeless assistance programs as well. There's a lot more we can do to collaborate and ensure that we're really broadening the conversation and thinking about housing in a more innovative and inclusive way.
We want to follow this up, and we have at least one meeting coming up, and probably will not be the only one, where we're bringing some folks in this space to figure out how we solve this problem. And we'd like to make sure that your officers, as I said, who you designate, are a part of that. I don't know too many school children. And you know what I'm getting ready to say, too many school children across the Commonwealth, in all communities, rural, urban, suburban, are living a homeless reality. And one month they may be in one school, another month they may be in another school, another month they may be in school a third, or shuttling back because of their circumstance. Maybe even living in a car. I remember Senator Haywood, I participated with Senator Haywood in his poverty tour. I know you remember that. And I know we witnessed circumstances where folks were living out of their automobile in very poor health conditions themselves, but living out of their automobile. That's not the Pennsylvania that we need to be, and especially in the environment that we have right now. Where resources are not a challenge. We need to, be our best selves, if you will, and figure out a way to do this, especially with children. Children, homeless. We can do better. We can do better. I won't belabor the moment, Mr. Chairman. Again, I want to thank you, Secretary. This is There's not too many of your partners, too many other secretaries who have a whole day devoted to them. All right, I think Secretary of Education's got a whole day devoted, and that's later this week. But thank you very much, and again, thank you to your entire team of 16, 17,000 individuals and all that you administer. It's 2 years almost to the day when the world stopped. And your team was on the front line of dealing with the health impact of that, and also Department of Health. And we appreciate the ability to kind of manage that well. So thank you very much. Thank you, Madam Secretary. Thank you, Mr. Chairman.
Thank you, Chairman Hughes. I think Secretary Sneed volunteered for a whole day.
She had a lot to say, Mr. Chairman.
Yeah, that's been traditional because 75% of all of our investment is in two areas, human service and education, so it's just really important. And Senator Hughes had focused on how important what you do is. That's indispensable and undeniable, especially during the toughest 2 years that we had in our lifetimes. And you know, your 16,000 associates have stepped up and accommodated their mission and did it for the people that we care about, and they should be applauded by everyone. The 12 million people in the state should be applauding the 16,000 people in human services what you did. And on behalf of our team here, I just wanted to pass it on to you, and hopefully things will get a little easier now, hopefully. I think some things will be a little more permanent than we expected. You know, some of the work environments and experiences will be different. Challenges that we'll have in filling positions will continue. But I hope there'll be some silver linings to this experience in regards to the flexibility that people have to do their jobs. And no doubt, if that's more appealing to a lot of workers, they've definitely earned it, if anything. So I want to acknowledge you for that on the start. A lot of conversations today about the close of, I think, an administration-long attempt to try to nail down the path for our MCO healthcare system going forward, something that was first initiated, the managed care system for healthcare, physical health, behavioral health, back in 1995. And anytime you do this, there's going to be challenges in many regards. One of them is in transition. I know you can't get into specifics regarding who's going to be part of this going forward, but I would expect that there's some that's going to be new ones in, MCOs in, and old ones out, possibly. If it's possible to at least indicate to us, if you have any idea how many of our recipients would be affected by this transition, that would be helpful. Do you have any sense of that at this point, in that transition of health plans?
The transition, say that last part again, I'm sorry.
Number of recipients that would be potentially affected by it.
Well, my goal is certainly through the transition to ensure that nobody is impacted with the exception of those of us that may be transitioning out of a job and into a different job. That the bread and butter of the agency is to provide services to more than 3 million people across the Commonwealth who need it. And the agency needs to function whether I'm at the helm of it or anybody at this table is in their jobs seamlessly. So that is our goal, and we're hopeful that it will have no impact on the residents that we serve.
There's going to be, I guess, anytime there's transition, different health plans, building different relationships, it's going to be a challenge, and hopefully there can be a smooth transition in that. There will be concern regarding whether the current provisions of the contract that are being discussed today could be something after having some challenges over 7 years, and obviously the legal system involved, whether it will be possible to meet that July 1st deadline and nail that down. Several of our members have expressed some of the concerns there, and obviously the department's objectives to move forward. I guess we'll see how that works. The one thing that's also involved here this year if I'm correct, the process the department will go through to negotiate CHIP contracts as well. That the CHIP program is in negotiation for renewed contracts or new contracts. Would you expect that in those contracts, the things we're looking to include in the MCO contracts will be consistent? We'll have that same conversation regarding CHIP contracts too? Do you expect?
Yeah, well, if it's okay, we'll bring Sally Kozak to the table. She's our one deputy who has not had the pleasure of joining me today. She's our Office of Medical Assistance Programs deputy.
I know.
Yes, we have to swear you in.
Oh, swear me in.
You stand to be sworn, please? Thank you. I'm sorry. You swear the testimony you're about to give is truth, whole truth, nothing but the truth. Please swear or affirm.
I do.
Thank you.
So the CHIP program is currently slated to extend until 2024.
Okay.
We will be going out with a new RFA later this year. The implementation date will be April 2024. But the CHIP contracts as they exist will continue to be renewed for the next 2 years.
And some of the thought process of that is to have the MCO contracts in place first before we go forward with the CHIP procurement?
It's just a matter of timing. Back in 2016, with the managed care final rule, CMS mandated that CHIP programs become more in line with Medicaid programs. In order to do that, we had to make some system changes on the CHIP side because they were two different systems. And so that's what we've been moving to. Those system changes will be completed in 2023, which will then allow us to begin to move forward with converting more of the CHIP program into our Medicaid systems as well.
And
So it's
obviously,
just
I'm sorry, go ahead.
I was going to say, it's just a systems timing issue.
And obviously, and we all learn from experience, any experiences we had in trying to move forward in the MCO contracts would be accommodated in this process too, I would expect, right?
Correct.
Okay. And the past practice of accepting all qualified bidders for the CHIP procurement would also extend forward, you believe, when we go into that process?
The CHIP procurement will be slightly different in that it will be all qualified bidders.
Okay. Thank you, really appreciate it.
You're welcome.
It's a lot of time spent on it today, just had some follow-up questions on there. One of the things that DHS has been very accommodating in the last several years to do is to participate in an extension of our review process that involves performance-based budgeting. And I really appreciated this department's participation in that because without DHS's participation in this process, given the size and scope of it, our process wouldn't be complete. And there's a lot of things, a lot of activities that the department accommodates that it's just good for our process along with the public to know how things are performing and using that as a platform for improvement if we need to. Just as a review of that process, the third iteration of that process and the activities in there, a lot of the performance reviews in these activities were very positive. In Community Health Choices, which is a substantially important program for us now and growing, the MCOs are improving measurements of service delivery, timeliness of critical incident reporting is improving, outperforming nearly all their benchmarks. It's good to have these evaluations and the performance against them. There was one note in terms of health status regarding A1C increases, diabetes. The incidence of control of those was a point of concern of the review. One thing, I don't want to spend time here actually in response to these, but if there's anything that, if the department can follow up with any action plan that may be taken on in order to pursue potential, identify weaknesses, which frankly, in regards to this very comprehensive review, there wasn't many. In the Child Care Works program, wait lists are declining. Families are receiving services faster. The numbers enrolling in child the STARS program 3 and 4 is increasing. The numbers in the ChildWorks program in general is declining a little bit, but we're seeing an increase in the areas that we had put in place a long time ago to advance quality in the STARS 3 and 4 programs. Just one question on that. Any concern regarding total participants in Child Care Works in the Child Care Works program, the fact that those numbers are falling? Is there any initial concerns on that right now?
Excuse me. I think, yes, we're concerned that numbers are falling. I think that that is a sign of families not being able to get back into the workforce either because of a lack of availability of childcare, whether that be staffing related or COVID related. So yes, it is something that we are certainly watching.
That is something we've heard regarding one of the downsides, saying the entire experience, the downsides of the pandemic, that the number of facilities has declined. The total number of facilities that are out there for families to have access to, that has declined. So we'll have to, take a thorough look at that to see what we need to do in order to respond to that. The share of STARS 3 and 4 facilities is growing, even though our incentive funding remains below its peak. So there seems to be a move, which is always the plan, at least over a period of time, to get more of the facilities to take on the benefits of STAR 3 and 4 categories. And that is something hopefully we can continue to advance. The things for the future, and I just want to put this on the record regarding the interest of continuing to move this forward. The LIFE program, I think, is a very important component of our long-term care system. There was many, I guess the best way to summarize this, a need for additional data and recommended measurements in order to evaluate the performance of that program. Can you accommodate those going forward, you believe, in the LIFE program? But most of it was just input-based, how many participants, cost for participant, but in terms of outcomes-based measures, there wasn't the data set available in order to do that.
And I think that data set comes from the LIFE providers themselves.
Yeah, but these were recommended measures for the next iteration that we would look to do. I'm only saying this from a standpoint of our next steps, that in reviewing this process for some of these activities, we would look to make it more robust, I guess, going forward. And I just want to note that for the record. And then in family visiting, home visiting and family supports, Nurse-Family Partnership records gains in postpartum care and depression screenings, positive results there. Activity 10, the Children's Health Insurance Program, satisfaction for care increases. Reports on child mental and emotional health dropped sharply in 2000. That is probably something that we would expect as a result of the pandemic. So that's something we'll have to take a more thorough look at. And in the Women, Family, and Victim Services, there is, again, and we're looking for some additional measurements there in order to make this more comprehensive. So we'll have to work together on some of the recommended measures there in terms of the Women, Family, and Victim Services programs to provide greater measurements for performance in that. So just a really quick review there, but I wanted to thank you for your work. That was very important. Some just follow-up questions in regards to programming that some members might have brought up, but I just wanted to make sure we covered the most important items here. In the child support enforcement line, Pennsylvania Child Support Enforcement System, there's a reference to an initiative, about $4 million of a technology refresh. Let's just spend a couple minutes on that, what that means.
Yes, I can. So in child support enforcement is a shared partnership between the courts of common pleas and their domestic relations section who create the orders and the department who collects the child support. That technology refresh, I believe, is part of a multi-year process to move off of the mainframe and onto a more open platform. Is that a fair? I just want to note I did that without even looking at my notes.
Community Health Choices, $407 million for rate increases this year, $304 million for member month increases. The rate increase percentages, what are we looking at there this year?
So that first line is not all a rate increase. There's a change in case mix, there's a change in the utilizations, the kinds of services that are being utilized by the individuals, and there is a projected rate increase of 3%.
3%. Do you believe that given the concerns we have regarding rising inflation, that's something that will not lead to supplementals going forward?
We think it's reasonable and in line with past trends. It's certainly something that we'll continue to monitor.
It's hard for actuaries to actually, throw an accurate dart right now because we have, tremendous changes in just the value of the dollar. So it's going to be interesting to see how accurate we are here. Same thing in medical assistance capitation, $218 million rate increase, 3% there as well.
In the behavioral health and physical health programs, that's actually a projected 4% increase.
4% there. CHIP premium arrearages, $17.7 million. What does that indicate for?
Sure, so that's to cover back payments that families who received subsidies in the CHIP program were not able to cover. So we're offering to pay those arrearages through that appropriation for those subsidized CHIP families.
To subsidize payments that they would otherwise make?
They would.
Already.
A commercial playing. I'll let Sally speak more specifically because there are 3 tiers to the CHIP program: free CHIP, subsidized CHIP, and full cost CHIP. But Sally can talk specifically about the arrearages.
Yeah. So during the course of the public health emergency, we would not allow the CHIP plans to disenroll any child who couldn't pay the premiums. Since then, a number of families have been making payments but are still struggling to come completely whole with what they owe. So what this would do would allow us to go ahead and make the MCOs whole with what would have been paid by the families, and then go forward, the families would once again be responsible for covering the entire amount.
Their arrearages would be something that there would still be an obligation of the family? Is this satisfying their outstanding obligations?
This would satisfy their outstanding obligation.
Okay. County Child Welfare, $150 million for a need-based budget, a little higher than it has been in the past.
It is. It's roughly a 5% increase, which generally in the past it's been somewhere around 3%.
All right, and this lastly, I just want to, I have to go through a small math exercise with you, okay? Because part of our exercise this year is a little different than in prior years, that we've been, for the most part, we tend to do just an annual review, okay? There's an extended goal this year because we're being supported substantially by our partners in Washington. And our goal, and I think the governor's goal too, is to come out of the overall stimulus period in fiscal balance. His proposal provides for that. That at 24-25, we have a $34 million surplus in his proposal. Okay, and that's smart because we're looking to appropriately partner with our federal officials so that when they give us substantial assistance for revenue relief, that at the end of the period of time that we come out in fiscal balance. And some of that is a learning experience from the past, from 2010, where we try to project out where we were going, and then we end up being in a big fiscal hole. Just trying to learn from that, but also accommodate what is an effective partnership. Now, in doing that, the administration, in its projections, has percentage increases for this year in a spending proposal, and then projected out to the end of the stimulus period. The increase that is presented this year is around $6.2 billion. It leaves a surplus, $3,382,000,000. In 23-24, $190 million is the projected increase, which is about 0.1%. It leaves $1,164,000,000 in the ending balance for that year. The end of the stimulus period, $34 million is the ending balance, and a projected increase of $600 million in that year. Okay. Now, if we look at the Human Services budget, is the all-compelling conversation as it relates to our ability to be sustainable. It has been for decades and will continue to be, because it includes significant investments in mandatory programs that we all want to do but require us to make investments. And they are, by definition mandatory, but they're also things we know are important for the many families in our communities. And I think these programs that we've set aside dollars for have certain historic trend lines to them in regards to the utilization and the rate increases. And I think in setting projections, using those historical trends is probably, at least in my experience, the best way to go, okay? So in the three major categories, as we had talked about, for our entitlement programs, the capitation program, we have a $450 million request for additional funds. Community Health Choices, that's $407 million, state funds. $304.5 million for rate increases for Health Choices MCOs. Total combination that we need to do this year for those three is $1.2 billion, okay? And we have to assume that if we're about at the same level, maybe we won't be, but based on the history of the last 10 years, there's some consistency here. That's $1.2 billion for 3 years, that's $3.6 billion, okay? Then we talk about the initiatives, and some very important initiatives here, that a lot of us would support. But the accommodation for these initiatives is, based on our math, is $364 million for 22-23. Goes up to $526 million 23-24, and then $862 million for 24-25. We just have to carry the difference between the 2 years as what is necessary for us to set aside. So the total we need to set aside in order to accommodate these, and we're looking at these as recurring initiatives. They're proposed as recurring initiatives. $863 million. So you put the $3.6 million, top of that, the $863 million, that's $4.4 billion in total that we're looking to carry. If we use historical experience based on what we know and what we've seen in the past. Human Services budget over the next 3 years, into the end of the stimulus period, after this year, is projected to go up by $718 million. So that's $4.46 billion, based on our estimates, as compared to a published projection of $718 million. That's $3.7 billion difference, which turns that $34 million surplus in 24-25 into a $3 billion hole. Now, I know we have to reconcile this, but we're going to have a tough time based on our collective work together and knowing what we've had to accommodate in the past, and the collective work we've done on these programs to try to find how to reconcile in the spending part of the equation to a place where we're fiscally balanced and we're going to accommodate these proposals. The revenue proposal is a little more fluid because, and members should be acknowledged for the fact that they are arguing for a dynamic modeling in revenue estimating. We invest more in our economy, it grows more. So that variance is, I think, a little more fluid. Is the IFO right or is the Department of Revenue right? But here we have history and accommodating programs based on caseload utilization and rate increases that would be, in my estimation, the only way to go about trying to estimate where we're going to be. And I just don't want to repeat where we were in 2010, but having to have a very difficult conversation on filling a hole that's necessary in order to take care of our folks that we really want to take care of. Now, Madam Secretary, it'd be good for us to work together through and reconcile these, but if you want to provide any commentary at this point in time or to justify any of this in relation to where we see it going, I would much appreciate it.
Absolutely. If it's okay, I will let Gloria do that projecting because I think she can speak more intelligently to it. But I will say that we generally use conservative estimates for those out years. Yeah, go for it.
Yeah, so I think there's a couple pieces that we have to take into consideration. And the two drivers really are the capitation program and the community health choices program. But the community health choices program doesn't have a 10-year trend line, right? It was just fully implemented last year. So we do build what we believe is a conservative but reasonable trend moving forward in that particular program. I think the other impact that you see in the capitation program is the impact of minimum wage. We've built that into our out years, and it does, as the minimum wage goes up, continues to assume that individuals will disenroll from MA, which results in savings in all of those out years in that particular appropriation. I think out years are difficult at best. There are a lot of things that can change in the economy, at the federal statutory level, at the state statutory level. So there are things that we're going to constantly have to monitor. I think it's hard to do a prediction today for 25, 26, or 26, 27 that we could all, in years from now, say is great.
Let's just stay 2 years out, 24.
Even 2 years out.
We're just trying to accommodate where we are when the federal government is no longer in our treasury. As long as we don't see another, huge problem that they believe they, for the right reasons, need to subsidize, we're just looking to the end of the period. And based on what you're telling me, if we're going to accommodate the initiatives that you would like us to consider, which on a cumulative basis, $863 million, we're pretty much going to sit here and say that the three programs that are the fundamental issue in regards to our fiscal deficit will not grow at all. Will not grow at all because it's the initiative spending in and of itself is bigger than your projection.
It does take into account those savings that we anticipate seeing from minimum wage, should it be implemented.
Minimum wage will accommodate taking these programs from historic growth of where they are to zero.
I'm not saying that. I'm saying there is a small increase from year to year to year, which we do believe, again, we're going to keep using that word. It is conservative, but we believe it's reasonable. I think one of the other things that makes the growth, particularly from 21-22 to 22-23, look significant is that loss of COVID-enhanced FMAP, right? So we had $2 billion in COVID FMAP for one particular year. So of the 3.4% or $3.4 billion increase, $2 billion of that is just losing the COVID FMAP, right, and the other COVID impacts. So I think there's a lot that's impacting those projections for out years, but we're happy to have conversations about them.
We have to, because the human services budget over the last 10 years has gone up by 6%, and we're projecting it to go up by lower than 1%. And that's fundamentally based on all the standards you use to forecast, I think, impossible. The minimum wage savings in regards to the revenue estimates you're having don't come close to what's necessary to level out the growth of these programs. It does help based on your projections. Now, there's differences of opinions of whether you can book a revenue gain from a minimum wage increase. But in terms of scale, and we'll have to have this conversation with, obviously, the budget secretary, in terms of scale, it doesn't match up to that significance of change. We are fundamentally saying that the experience we've had in these programs and the demographics we need to accommodate and the services we want to provide and the growth of them over a period of time over the last 10 years stops this year. It ends. That we have no further growth in these programs. And it's the only way to balance out at the end of that stimulus period and sustain the governor's request the spending increase request that he wants for this year. That's the only way to do that. So I think we just have some work to do. All right, really appreciate it.